As nurses, neurological disease and injury are going to be some of the greatest challenges that we're going to see in the rehab facility. They can be very devastating to the patient and the family and very challenging for the nurse to take care of. So it's really important that we learn and understand about the neurologic system. Now this is an introduction, so it's just going to get us started on understanding the brain and its function. And then we'll go on and learn more about diseases in the next chapter. So let's start with this coronal section or cross section of the brain. Now it is in your book on page 347, so you can take a look for a better picture if you want. But the basic part of the brain is the cerebrum. That's the largest part of the brain. In the middle of the brain is the thalamus and hypothalamus. And the little cauliflower-looking organ at the base of the brain is called the cerebellum. Now, I think that's kind of an ugly organ, but it has its function of balance, which we need. Then we also can see the spinal cord and the brain stem, which has the midbrain pons and medulla oblongata. So as we go along, we may be talking about some of these areas of the brain. So I want you to get a picture of this cross section. So let's talk about some of the anatomy and physiology. The thing about the brain is that it receives and interprets information from external environment, and then it initiates a response to that information. So the brain, let's talk about the brain. It weighs about 3 pounds, and it consists of the cerebrum, cerebellum, and brainstem. And it is composed of right brain and a left brain, or right hemisphere, left hemisphere. So it's the cerebrum is divided into two halves, as I said, called hemispheres, and are connected by the corpus callosum. Each hemisphere controls the opposite side of the body. So the right hemisphere controls the left side of the body, and the left hemisphere controls the right side of the body. For most people, the left hemisphere is dominant, and this hemisphere controls the most analytic mental processes such as language acquisition, mathematics, and reasoning. The right hemisphere encompasses emotional and artistic tendencies. I know a lot of people like to think, am I a right brain person or a left brain person? Well, figure it out when you look at that definition. So the cerebellum is located at the back of the brain, and it coordinates movement, balance, and posture. The brainstem includes the midbrain, pons, medulla, and it's part of the reticulating activating system. The brainstem controls basic functions like respirations and consciousness. So brain circulation. I'm going to show you a picture, and there is one in the book about the brain circulation. It's rich with arterial circulation to satisfy the need, because remember, our brain thrives on oxygen. If it lacks oxygen for 4 minutes, it begins to die. So the brain circulation is basically fed from the carotid arteries, and those carotid arteries are a direct offshoot from our aortic arch, from our heart. So it's very rich blood. The spinal cord extends from the border of the first cervical vertebrae to the level of the second lumbar vertebrae. And there's 32 pairs of spinal nerve roots. The peripheral nervous system helps to maintain homeostasis, the autonomic nervous system. So it's an autonomic, it's automatic, and it controls our involuntary muscles of the viscera, smooth muscle, cardiac muscle, and glands. We don't have to think about it. It just automatically works. Now, stress can trigger the sympathetic nervous system to increase the epinephrine, norepinephrine. And this is our fight or flight mechanisms. And these are, the epinephrine and norepinephrine are called neurotransmitters. The parasympathetic nervous system mediates a rest response. Now, I call it rest and digest because in NCLEX they call it that. So we might as well start getting used to sympathetic is fight or flight, parasympathetic, rest and digest. Now here's just some zones of the brain, which is on your page 348. The reason I have this one on here is it's important because the first picture just kind of shows you see how the brain just looks like a pathway with little fissures? Those fissures are called sulcus. And you can see the central sulcus divides part of the brain. You've got the frontal lobe in the front of the brain, the parietal lobe towards the back, and the occipital lobe is directly in the back of the brain. That's where the optic nerve goes straight to the occiput or occipital part of the brain. And then the temporal is in your temporal lobe or your temporal temples. Then if you look at the colored part of the brain, now it doesn't look very good on the slide, but it does look good in your book. So there's a couple of things that I want you to look at, and they're green dots on the picture. And one is called the Broca area, and that's a motor speech area. It produces speech. Now, the reason I'm talking about these particular areas and why these areas are important is when there's a stroke or an injury to certain parts of the brain, you're going to get whatever that part of the brain does, it's going to be damaged. So there's a lot of times there's a stroke in the Broca area, and that's the area that produces speech. So those patients can't speak. One time I was in the grocery store, and there was this lady pushing the grocery cart, walking fine. She looked fine, but she carried a little chalkboard with her, right? And I just kind of smiled and said hi. And she didn't speak back to me, but she wrote me a note, and it said hi. So she obviously had had a stroke where she couldn't speak, but the rest of her was fine. She was walking fine, pushing the cart fine, but she couldn't communicate. So she probably had a stroke in the Broca area. And then if you'll see the other area of green, it's called the Wernicke area. Now the Wernicke is the comprehension of speech. So if you spoke to the patient who had a stroke in this area, they may not be able to comprehend what you're saying. If you tell them to lift their right arm, they won't understand. So when we understand about injuries to the brain, then we understand about the responses that our patient elicit. So it's really important that we be understanding. Okay. Now this is just a picture of your cerebral spinal fluid, which is very important. You can see the brain stem, and that is the area where the cerebral spinal fluid is made. This is the choroid plexus, and the cerebral spinal fluid is made there, and then circulates around the brain and down through the spinal cord and softens the blows. So it's just a fluid that if there's any kind of injury, jiggling, there's a little bit of liquid space there. But on the other hand, if that space, the fluid in that space gets an infection, then we have an infection all around the brain, all around the spinal cord. Meningitis, good example. So again, understanding that helps us understand how our patients react. Okay. Now I put the neuron in here several times, well, twice, okay, because it's important. The neuron is the functional unit It's important that you remember that. The impulses must pass from one neuron to another. And imagine we have millions of neurons in our body that are constantly sending messages to our brain, and then back to our spinal cord. Well, in between each functional unit or each neuron is a space. And that space is called the neural synapse. So that's the space between the axons. And what is required in that space is a neural transmitter, so that the neural transmitter helps that electrical impulse jump to the next neuron. Now, if there's an injury in any of this neuron, you can have illness or difficulty in functioning. So again, let's look at this functional unit, the neuron. You've got the dendrites. That's a spider-looking thing with the egg yolk in the middle. That's why I had to describe it. And then you can see the axons, and they're covered with a myelin sheath. Now again, that myelin sheath can, if there's damage to that sheath, you're going to have symptoms. You're going to have an illness. And if there's any injury in the neuron itself or the dendrites, you're going to have illness. So let's just be sure that we know that the neuron is the functional unit that carries an impulse from one neuron to another, and that synapse or space in between is the neural synapse. So this is just a picture, and it is in your book on page 350 of the intense cerebral circulation. Now this is looking from the base of the brain up, but you can see it's rich with blood. Major circulation, arteries. So if there's a clot or an injury or a bleed, you can imagine how damaging it can be. Now, I want you to remember that the brain is enclosed in the skull. The skull is a casing of hard bone. So if there's any injury or swelling in the brain, there's nowhere for it to go. I mean, if we injure our arm, it can swell up, right? It's nothing stopping it. But when you've got a skull, it's going to keep that swelling inside, and then that puts pressure on the brain, which causes symptoms. If you have a bleed, it takes up space in the brain, and then you're going to lose some function where that bleed is, or a clot that blocks the circulation to that area of the brain. You're going to get symptoms. So it's really important that we know how rich our blood supply is to our brain. All right, let's talk about some age-related changes, and that's on page 350. So the number of nerve cells decreases. Brain weight is reduced. Ventricles increase in size, however, but the weight is reduced. Now, I do have a couple of stars because I think they're kind of important for these things for us to know these things. Lipofuscin is an aging pigment deposited in nerve cells with amyloid, which is a type of protein. And you may recognize that word amyloid, and you may recognize the word tangled fibers, which is the next sentence, increased plaques and tangled fibers. And those are used when we talk about Alzheimer's disease. So amyloid and tangled fibers we've heard before with Alzheimer's, but they also are age-related changes. The eye pupil is smaller and responds to light more slowly. And you may have noticed this when you do your perla on your head to toes, that it's kind of hard to see a pupil response because the pupil is smaller unless they've had some kind of eye surgery, or if it's cloudy, a cloudy lens that you can't see the pupil very well. But it responds slowly to light. And that's just an age-related change. It doesn't mean that there's an illness. Reflexes are intact, except there is an Achilles tendon jerk, which is often absent. But we don't check a lot of reflexes as nurses. We see responses to things, but the reflexes, the neurological reflexes, is more of an advanced testing that our physician would do. But it's good to know, right? We have to know about things. Reaction time increases, especially complex reaction. Tremors in the head, face, and hands are common, and you may have seen that. Some patients develop dizziness and problems with balance, and remember that's that cerebrum, that part of the brain. Okay. Now there's some types of disorders that can potentially cause neurological problems. There's developmental and genetic disorders. Those include structural problems such as hydrocephalus. An example of a genetic disorder is Huntington's disease. Trauma. Central nervous system injuries resulting from trauma can be life-threatening and severely disabling. Physical trauma to the nervous system may follow accidents, injury, violent crime, or chemical injury. And that includes drugs, alcohol, and other harmful substances. Inflammation and infection. So meningitis and encephalitis. Examples of disease states that cause inflammation of meningeal or meninges of the tissue and brain. It could be bacteria, vectors, neoplasms. So tumors can be primary or metastatic in origin. And we often hear about brain tumors by themselves, but we also hear, and breast is that's one of the places that metastasis of the brain, of the breast goes, is to the brain. Degenerative processes. The primary degenerative disease of the brain is Alzheimer's disease, a progressive condition that begins with memory loss and results in severe mental and physical deterioration. Vascular disorders. Any factor that interferes with blood flow to the nervous tissue can lead to cell death and result in loss of function. Nerve tissue is so sensitive to hypoxia that cells begin to die after 4 minutes. There are vascular abnormalities as well, including aneurysms and AV formations or arterial venous malformations. Maybe you've heard the word berry aneurysm. Berry aneurysm is an aneurysm that people are usually born with. Excuse me. And some women in labor, when they're bearing down and pushing the baby out, they have been known to have a stroke or an aneurysm rupture because of the intense pressure inside the brain. I'm going to talk about intracranial pressure and how it affects the brain so much. I had an aunt who died of a ruptured berry aneurysm. No one knew she had it. Just one day, bam, it blew and she was gone. And not to scare you, but that can happen sometimes. We're looking at this from a nursing point of view. So metabolic and endocrine disorders, the brain depends on a constant supply of glucose and other nutrients. So remember that when you're studying for your test. Eat well. Feed your brain. It requires nourishment. And electrolyte imbalances can lead to deterioration in your thought processes and the level of consciousness. Neurologic dysfunction can result from toxins, poisoning, renal failure, and liver failure. And we've talked about some of those. Cirrhosis can lead to the brain being confused. Oh, here we go, another picture of an axon. Must be really important. So you've got this picture in your book, and it talks about the dendrite, the Golgi apparatus. This gives you a really good look, though. The axon, the Schwann cells, the myelin sheath that covers the nerve cells. And MS is a disease that occurs when the myelin sheath begins to deteriorate. And then where the synapse takes place, the knobs, or where the receiving end, where the dendrites receive incoming messages and the axon convey outgoing messages. So that's important to know. So I ask again here about the neural synapse. What is that again? It's the space between the dendrite and the axon, where the neurotransmitter helps the jump across that space. The neural synapse is a space. Not a big space, obviously, because we have a lot of axons. Think of how many that we have that go from the brain to our arm. Let's say we touch the table, and the table sends a message back to our brain so quickly, but it's following these axons. The message is going away from the brain and back to the brain. Amazing. So let's talk a little bit about nursing assessment of neurologic function. So we want to evaluate our patients for orientation to person, place, and time, asking them their names, where they are, what time it is. We want to evaluate their pupils and the response, the size, the shape, the reaction. We want to assess their neuromuscular response, which provides a means of evaluating cerebral and spinal cord function. So let's start with our health history. So we want to document. Always remember documentation. So important, because if you're going to be the one taking a history, you want to take a good history and you want to document it. It's going to help the doctor, it's going to help the next nurse, it's going to help the patient. So describe any injuries that the patient has had. Why are they here? Have they had a stroke? Do they have a neurological disease? What's their present health? Are they alert, oriented? Do they comprehend? Can they follow commands? And then their past health history. Any neurological disorders? Do we see any signs and symptoms that we would trigger in our mind something that's going on with the patient? Have they had a head injury or seizures? Previous stroke or TIA? So that's transient ischemic attack. And TIAs come and go. Sometimes the patient will present with a TIA, maybe a little facial droop, maybe they'll stumble and lose their balance, and then it comes back. So that's a TIA. Mostly it's usually caused from a carotid artery, maybe a plaque buildup. Also, we want to record those basic serious illnesses: diabetes, hypertension, heart disease, liver disease, gout. They have a history of cancer. We also want to know about their immunizations, their list of current medications. A lot of patients just bring in their whole meds, the bag of medicines that they're on. Then you can see exactly what they're taking, especially if they come from home. Of course, if they come from the hospital, they'll come with a list. Also, then we want to talk about the family history. Were there any diseases in the family? Any neuromuscular disease? Do they have risk factors? And we want to do a review of systems. So, your head to toe. Talk to the patient. Do they have any weakness? Do they have any impaired movement? Do they have any trouble swallowing or trouble having a bowel movement or urinating? How's their vision? Can they see? Is it blurry? Do they see out of one eye better than the other eye? We want to observe their general appearance, how they respond and behave, their level of consciousness. So important. I have it in red here because it's so important. It's reliable of their neurological function. It's so important. We also want to assess things like their breathing pattern. We want to listen to their lungs, assess their hydration, their respiratory effort, as I said, in their lung sounds. Inspect the face for symmetry. Is it equal, or do they have a droop or a drooling? Looking at their pupils, assessing their pupillary response. All their extremities, can they move them all equally? Are their hand grips equal, or is one weaker than the other? Do they have any impaired movement? Do they have aphasia, lack of being able to speak, or dyspraxia, trouble with movement? That can mean neuromuscular damage. So neurochecks, so important. And a lot of times we have to do a focused assessment when we get a patient in, or if we have a symptom of a neurological development in our patients, we would suddenly do a focused assessment. And that would be a neuro check. And that consists of level of consciousness, the pupils, response to light. Do they follow commands? Do they have sensation and movement of their extremities? And of course, then are their vital signs, because we're going to find that their vital signs are important. Their blood pressure can indicate something. And the intracranial pressure, which we're going to talk about some more. So I'm just going to go again about the basic neurological exam, that level of consciousness, how important that is. It's accurate and reliable in a neurologic function. Most reliable. So I'm going to go to the next slide because I have actually put the level of consciousness. I've broken it down for you because it's that important. It requires its own slide. So the first thing I want to talk about is somnolence, and that's an unnatural drowsiness or sleepiness. Lethargy is used to describe excessive drowsiness. Stupor suggests decreased responsiveness accompanied by lack of spontaneous motor activity. Stuporous. They can be aroused. A patient who cannot be aroused by painful stimuli is comatose. So you've got semi-comatose, they're in a stupor but can be aroused. A patient who cannot be aroused by painful stimuli is comatose. Now, I talk about this painful stimuli. It can also be called noxious stimuli. So what is that? Well, when you're trying to wake a patient up and you call their name and they don't wake up, you shake them a little bit, they don't wake up, you might have to elicit a painful stimuli or a noxious stimuli, like pinching their fingernails, their nail beds with your nail, or rubbing their sternum. That will wake somebody up. Boy, if you do that to yourself, it's painful. So a patient who cannot be aroused by painful stimuli is in a coma. So I have to tell you this because I had a case from the state about a patient. The nurse peeked in at 7 a.m. and saw that her patient was asleep. It was a guy. Saw his patient was sleeping. Didn't think much about it. 7 o'clock in the morning. Just wanted to make sure they were breathing, right? So the CNA goes and takes their vital signs at 7:30 and comes back and says, their blood pressure's up a little bit. And he goes, oh, okay, well, thank you. 8 o'clock, lunch, breakfast time comes, and the CNA sets the patient up to eat. Patient doesn't wake up, even when the head of bed is lifted up. CNA goes and tells the LVN. LVN goes, okay, well, patient must be pretty sleepy. Maybe didn't have a good night. So 9 o'clock needs a brief change. Still didn't eat breakfast. So they did a brief change on the patient. CNA did. And the patient still didn't wake up. So she goes and tells the LVN. The LVN goes, well, pretty sleepy. But nothing, doesn't think something's wrong? Come on, guys. This is when we have to act. If you have a gut feeling that's not right, go look at it. It's much better to investigate and see for yourself, not take someone else's word. See for yourself if what is wrong with that patient. Maybe you can catch something in evolution, maybe a stroke in evolution. This patient was having a stroke. It wasn't caught until 11 in the morning, and that patient did die later that afternoon. But when looking back on the records, 6 a.m., she swallowed her medicine. Well, something happened after 6 a.m., between 6 a.m. and 11 a.m. 5 hours, something was happening to that patient. And interventions may have saved her life. So pretty passionate about being very on top of changes in condition. Check it out. If you have a gut feeling or if you get something that's abnormal, look into it. It's better to do it that way and have it be nothing than to have it be something and you didn't check it. All right, so again, level of consciousness, very, very important in a neurological exam. So this is just an adult neuro flow sheet. So if a patient fell or maybe, and hit their head, they're going to need a neurological checklist. They may need to be looked at every 30 minutes or so, or every hour. I think it increases over time how often you need to check them. But this is specific neurological level of consciousness, pupils response, motor response, and this would be the flow sheet. Okay. So before I get to the diagnostic tests and procedures, I just want to finish going through this physical exam, talking about the pupil evaluation. So you want to describe the pupil response. Is it brisk to light? Is it round? Is it reactive? The neuromuscular response, are they moving their extremities? Vital signs. So monitoring the pulse, respiration, and blood pressure is reliable information regarding a neurological exam. So elevated temperature could mean that there's infection or thermoregulation is impaired. The Glasgow Coma Scale, their eye opening. The advanced neurological exam is more done by the physician. Cranial nerves. There's a few nerves that we need to know about. The vagus nerve that affects the autonomic, cardiac, respiratory, gastric, and gallbladder function. We also need to know about the phrenic nerve, which affects our ribs, our rib cage, our breathing. We know the optic nerve is a cranial nerve as well. We'll talk more about that. Coordination and balance, the cerebellum and the cortex influence coordination and balance. So we want to know if the patient can move, if they can balance, if they can stand, if they can close their eyes and still be able to perform, touch their nose. And you can read about this on page 355. And also their neuromuscular function, and it's graded on a scale of 0 to 5. And if the patient's unconscious, some noxious stimulus such as pressure on the nail bed may be applied to determine whether movement is possible. And again, there's a grading scale, table 21.3, grading scale for muscle strength. And your cranial nerves are listed in table 21.2. The optic nerve is cranial nerve 2. I know there's some mnemonics to remember cranial nerves. If you Google or if you go to, what is it? The one, well, anyway, you can get some old Olympus Topsafin, and there's some other ones that go on. But anyway, what we will see is the optic nerve, which is cranial nerve 2, the trigeminal nerve, which is 5, and I am going to talk about some trigeminal injuries, facial nerve, which is 7, the vagus nerve, which is 10, and we've talked about vagal nerve, vagal stimulation. It also, the effect gag reflex. So those are just some cranial nerves there. Also, I just want to go to the sensory function on page 358. So many tests of sensory function exist. Perception of pain, temperature, touch, vibration, proprioception. What a great word. What that means is where you are in space. If you hold your arms out, do you know where your arms are? You know that they're out to your side, right? That's proprioception, where you know you are in space. And then we have checking the sensation of the hands and arms and all the extremities. I'm going to be talking about dermatomes. When I get to that slide, I'll talk more about that. It's a special part of the skin that's innervated by a nerve. Pain. Remember that pain is always described, not just they have pain in their arm. What kind of pain? Is it sharp? Is it stabbing? Is it dull? Is it achy? So we want to use those words. Temperature, this is all part of sensory function. Touch, tactile reflexes. Now, reflexes, oh, well, that's an important thing. So the Babinski reflex. So the Babinski reflex accompanies, now I'm on page 359. The Babinski reflex accompanies abnormalities of the motor pathways originating in the cerebral cortex. Assess for it. Now you can assess this one. You can assess for a Babinski by stroking the lateral side of the bottom of the foot and across the ball of the foot with a blunt object. It could even be your pen light. It just something that doesn't have to be, nothing that will stick them. And observe the resulting movement of the toes. Now you need to know the normal Babinski, which the toes curl downward. So if you did that scraping on the foot, their toes are going to curl down. Now if they came up in a reflex, and there's a good picture on the next page, page 360, of the Babinski reflex. So you can see the scraping is A of the foot, and then the B is the normal response, the absence of Babinski. An abnormal response, or the presence of Babinski, their toes spread out. Now, in a child up to age 2, they do have the toes spreading out, but that is not an abnormal response in a child. All right. So let's talk about some diagnostic tests while we're on this page 360. So lumbar puncture. Table 21.6 talks about lumbar puncture. It's used to diagnose infections and other CNS disorders. So the positioning of the patient is really important, and that's going to be on the next page, figure 21.11. They're curled into a fetal position, and you may have to help the physician hold their head and legs so that their vertebrae is spread out. That way the doctor can insert the needle in between the vertebrae, and purpose is he wants to get pressure, the cerebral pressure, so there'll be a pressure monitor on the end of the needle, and then they might remove that pressure gauge and take some cerebrospinal fluid, put it in a tube and send it off to the lab. They can see infection, they can, if there's white cells, they can see what color it is it bloody, they can see is it clear, cloudy, is there glucose in it, protein in it. So it is an important test. Important for you to remember is that after a lumbar puncture, the patient needs to lie flat because they have a risk of headache if they try to get up. So they need to lie flat. And that's under your post-procedure nursing care. And I've also highlighted in this slide. The EEG is used to detect seizure activity. This is an electroencephalogram, or EEG. That's electrical activity, and that's seizure activity that might be seen. Or if there's a lack of electrical activity in the brain, that may mean the patient has no activity in the brain, which means they're essentially brain dead. Imaging studies, a brain scan will depict a pattern of distribution of a radioactive isotope that's given to the patient. The angioplasty or angiogram is also listed here. And what's important for you to know here, so basically what it is, let me say, is that it's pictures are taken after an injection of contrast, so they can see all the blood vessels in the brain. But you, as part of the patient preparation, need to inform the radiologist if the patient's allergic to shellfish or iodine. I know that comes up every time, right? And every time that a patient receives a dye, just know you have to know what their allergy is. Is their allergy to shellfish or iodine? That can affect, because they could have a bad reaction to the dye. So the radiologist needs to know that, you need to know that. So the CT scan, well, there's a really good picture on page 363 of a CT scan. It's a cross section of the brain. So let me just say here, important to know, is that the CT scan is an excellent tool in the evaluation of trauma, tumors, and hemorrhage. Enhancement of an area may be achieved by injecting contrast medium. Therefore, an allergy to such medium must be reported to the radiologist. Also, the next page talks about an MRI, but it's also on your table, so I know there's a little shifting around there. The MRI is important, and I'll tell you why. So the MRI is a big magnet, and we know our body is made up of electrons. So an MRI looks at the way our electrons are moving in our body and forms a picture. But because it's a magnet, metal is very sensitive. And before you even have an MRI, they'll ask you, well, first of all, can you be in a tube? Do you suffer from small spaces, fear of small spaces, because you are in a tube? They do have large MRI machines for bigger people because that tube is pretty small, but they're very, very expensive machines. So only some facilities have an MRI machine for larger people. But what's important for you to know basically is that, does the patient have any metal in their body? Do they have a pacemaker? That's metal. Did they have a rod put in their body, into their spine? Now, most of the new hip replacements, knee replacements, they're titanium, and that's not metal. It's not going to be reactive in an MRI machine. They started doing that, using titanium because of this MRI machine. But metal, if it's in the body, or if the patient goes in with a bracelet or a ring on that is metal, it's going to be sucked right off of them. It's really amazing. So the radiologist, the tech, and the nurse, you'll get asked multiple times, do you have metal in your body or on your body? But pacemakers, because we're dealing with the elderly now, so they could have had something put in their body before an MRI machine. I remember our first MRI machine down at Cedars-Sinai was in the late 70s, early 80s, and it was a big deal because that giant magnet, boy, you couldn't go in that room. Even then, we were using metal IVs, so we had to change a lot of things because of that giant magnet. And of course, if you notice at facilities, if you have an MRI, it's far away from the building because it's so strong, and it is encased in very strong walls. All right, so under patient preparation, sorry, I got off a little bit there. Patient preparation for an MRI, notice that patients with some metal implants cannot be exposed to the MRI because magnet can cause metal to move in the body. So I gave you an example of a pacemaker, which some patients have pacemakers. All right, let's move on. Now this, I know I did this special. This is a picture of the dermatomes I promised you, which is also on page 359. And it really just shows you the area of the skin that a particular nerve root innervates, or we know it, herpes zoster or shingles follow dermatomes. So you'll see a line of blisters or pain. The patient will have a line of pain coming from the dermatome that comes from the spine and curls around the body. So that's your dermatome. Slide. So there are some common drug therapies. Some are used to treat neurological disorders. They include antimicrobials, analgesics, anti-inflammatories, corticosteroids. That will be used a lot in neurological disorders. Anti-inflammatory, because a lot of injuries are inflammation. Anticonvulsants, if a patient has seizures. Diuretics are important. If there's fluid on the brain, they might give a diuretic. Chemotherapeutic agents are used. Dopaminergic, anticholinergic, cholinergics, and antihistamines. They don't go into great detail about the drugs right here. But let's talk about surgery. It's on the same page there, page 364. So a craniotomy is a surgical opening of the skull. It corrects defects, evacuates hematomas, and relieves pressure after trauma. A craniectomy, ectomies are always removal, excision of the skull. Now, sometimes if there's swelling in the brain due to an injury or surgery, they will take out part of the cranium or the skull and save it. So they'll save it if they can, if it hasn't been too injured. And they may put it in a dish, a Petri type of dish, and keep it to keep it fresh and alive. Sometimes, if you remember when that tiger attacked the Siegfried and Roy in Las Vegas, and the tiger grabbed one of them by the neck, and his head swelled. He had some brain swelling. They took part of his skull out and implanted it in his abdomen. So it was part of his body, so that when they were ready to put it back, that the body didn't think it was an alien part, an alien extremity, or an alien, and reject it. They didn't want it rejected. So that's done sometimes. They can also use metal plates if that part of the cranium has been damaged. A cranioplasty is a repair of a skull defect. And that can be maybe, if there's some sort of a birth defect. So important for you to know about post-op care. So now when they go into the brain or even into the spine, they're going to interrupt that cerebrospinal fluid because they've got to get through to the brain. And there could be a leak after brain surgery. So on the dressing, you'll notice a CSF leak appears as a pink stain surrounded by a lighter ring described as a halo. That's very significant of a CSF leak, not link. All right, now important for you to know also, and a little bit further down on page 365, it talks about it. It says the physician prescribes the patient's position and usually specifies that the head of the bed be elevated 30 degrees. Now that's important for you to remember. Elevate the head 30 degrees. Cuts down on the swelling after surgery and also helps the patient breathe so they don't aspirate if they're unresponsive at that time. So, important. Now let's talk about increased intracranial pressure. So increased ICP poses an extremely serious threat to the neurological patient. Understanding the physiology as well as the signs and symptoms will enable you to recognize the problem and respond appropriately to prevent life-threatening consequences. So that's the pathophysiology. Basically, we know the skull is rigid. If there's any kind of trauma or injury to the brain or bleed, that takes up space. And it takes up space that's not really there. So it's going to push in on the brain, and then they're going to have symptoms of level of consciousness. So it's important to know and recognize that. And remember that level of consciousness is the most reliable indicator of mental status because it's extremely sensitive to oxygen levels. Change in level of consciousness is the earliest change seen in intracranial pressure. Very important to remember. Now another thing I want you to notice is pupils. So when intracranial pressure rises, you're going to get pupil changes. And this is when you hear words like dilated pupils, fixed pupils, fixed. It's usually said fixed and dilated. Blown pupil. Those are bad signs because there's an increased intracranial pressure. That can't last for very long because damage will occur if they stay that way. it talks about, if you're looking into your book, these changes occur because of pressure on the ocular motor nerve, the third cranial nerve, and that is late sign of increased intracranial pressure. Another major indicator of increased ICP is altered motor function. So when deficits are on the opposite side from the brain injury, they're said to be contralateral to the injury. In other words, if you have an injury on the left side of the brain, you're going to have symptoms on the right side of the body. So another sign of increased intracranial pressure is the abnormal posturing. And you may see this, like I remember we had a patient at a facility who had some trauma and was in a comatose state, but had posturing. And they postured a lot of times to pain. So an increasing pressure is exerted on the cerebral tissue above the midbrain, and posturing can be observed. Now, if you turn to page 366, you can see these posturings. So A is decorticate posturing, and that's where they have abnormal flexion, decorticate rigidity. Their arms flex up. You can see that in the picture, and actually their toes actually point down also. Now, the thing about this posturing is family will see the patient move and think, oh, they're moving, but they're not. This is bad. These are abnormal posturings. So that's something that we gently have to say to the family. These are just neuro responses. It doesn't mean that the patient is not in a coma. Then the second one I want you to notice is decerebrate, and that's the second picture. And notice how the arms go out and flex, the hands flex out. And that is to stimulation that they respond and have different kinds of posturing. So while we're on that page 366, there is another thing that's really important for you to know, and that is that intracranial pressure elevations, this is about the third paragraph down from the picture, evoke an increase in systolic blood pressure with little or no increase in diastolic pressure. So an example would be you take a blood pressure, and the blood pressure is 140/70. Then the next time you take the blood pressure and it's 170/70. The diastolic did not change. The systolic went up. Well, that is a sign of increased intracranial pressure. So it's extremely important to monitor vital signs in the neurological patient. And remember that changes in pulse, respiratory pattern, how they're breathing, and blood pressure are late signs of increased intracranial pressure. Important nonetheless. The combination of hypertension, I think this is on the next slide, let me go. Yeah. So, and I give you a picture here. I just want to talk about the blood pressure, 140/70 and then 170/70. It's a visual. So this is the systolic goes up, but the diastolic stays the same. And the change in pulse, regulatory pattern, and blood pressure are late signs again in the ICP. Cushing's triad, that's important in NCLEX. That might pop up, and there's three things that occur in the Cushing's triad: hypertension, bradycardia, and a widening pulse pressure. That's Cushing's triad. And that's associated with increased intracranial pressure. So medical treatment, though, before we go to the question, medical treatment, of increased intracranial pressure is vital for survival, so you need to let doctor know if you notice anything. Also, positioning can lower actually the ICP. Hyperventilation with a ventilator, if they have a tube, endotracheal tube, they can hyperventilate the patient and help decrease the ICP. Also fluid management, because the fluid around the brain and spinal cord is sensitive to fluids and electrolytes. We want to, they might need mechanical drainage, which would be like a tube that's put into the skull, into the brain, and it can measure pressure. It can also do drainage. I remember a patient I took care of one time that every 4 hours we were to check the pressure of the brain, intracranial pressure, and we were also supposed to check how much fluid had drained out within 4 hours. And if it was higher than a certain level, we had to contact the physician. All right. So another thing, sorry, before I get to the question, I want you to know is that it talks about, it's the very last paragraph of this chapter, and it says corticosteroids, although controversial, may be used to help decrease cerebral edema and ICP. They decrease the edema by lowering the elevated ICP associated with tumors. Dexamethasone or Decadron is a major agent used for patients with neurologic disorders. So they might get a large IV dose. These aren't oral. These are IV. And they would decrease the fluid amount, or they would decrease the inflammation in neurological disorders. So that's basically the drug in this chapter. Let's go to the question. So stress triggers the sympathetic nervous system to what? Give you a second. You've had a second to look at this probably already while I was talking. So what's the right answer? It's A. So stress triggers the sympathetic nervous system to increase the secretion of epinephrine. This is one of our sympathetic nervous system responses. The epi, and actually the norepi is increased, so when it says decrease, that's wrong, right? Because we have an increase in epi and norepinephrine. And these neurotransmitters increase heart rate, constrict peripheral blood vessels, raise the blood pressure, open up the pupils. So you can see decreased heart rate, that's wrong because it's more of an increased heart rate. And peripheral blood vessels, it's not dilated, they're constricted to increase the blood flow to the organs. All right, let's try the second question. Which of the following is not a normal aging change? Give you a minute. Now, this question is a good example of how you have to read the question carefully. Especially in this neurological chapter, the questions, read them very carefully. So the right answer here is C. The pupil of the eye it's not larger, is it? It's pinpoint, it's smaller. It's harder for us to see it with our pin light. So the pupil of the eye is often larger. That's not a correct statement. So it's not a normal part of aging. All the others are correct. So thank you for listening to this chapter, and I'll be lecturing on the next chapter. So thank you for listening.